Well, good afternoon, everybody, and thank you for joining us here at REACH. This is our first virtual webinar. It's taking place on two special occasions. One, we were supposed to be in St. Louis doing our in-person symposium. Due to obvious circumstances, we are not doing that this time around, so here we are. So thank you for joining us. And also, it is September, which is Hirschsprung Disease Awareness Month. So that also is a special month for us. REACH, everybody's here from the REACH board, Tory, Eric, Allan, and with us today is Dr. Gosain. Also will be joining us in the doctor panel, and we're just so thrilled that we were able to do this. REACH was established in 2011 by the Schneidig family, whose son Adrian was born with total colonic Hirschsprung disease. Together with Dr. Goldstein, the Schneidigs established REACH, which is a non-for-profit, and it is committed to improving the lives of children and families living with Hirschsprung's disease. So, without further ado, because I know time is an issue, I would love to introduce, first of all, Tory, my co-host.
Hello, how are you?
Tory is part of the mom squad today with me. Both of our children have Hirschsprung's disease, and Tory has been a long active board member. So Tory, I don't know if you want to introduce yourself. And
sure. As you guys heard, my name's Tory. My son Avery is 9 years old. He has total colonic Hirschsprung's, and I became involved with REACH when we met Dr. Goldstein when Avery was about 3 months old. So we've been part of this for the last almost 7 years.
Mm-hmm. Wow. And you had this amazing golf tournament that you would put on every year, if I recall correctly. So you were quite active in the fundraising department too.
Yes.
Yes. And that's a whole new thing these days, isn't it?
Sure is.
All right. So then why don't we go right to the first thing on our agenda, which is the, of course, the doctor panel. I would like to introduce Dr. Allan Goldstein, who is an associate professor of surgery at Harvard Medical School, and I love doing this, and a pediatric surgeon at the Massachusetts General Hospital, where he directs the pediatric, I can never say this word,
neurogastroenterology.
Thank you, program. He has a special interest in the care of children with Hirschsprung's disease and leads an active research program that studies causes, complications, and treatment. So that is Dr. Goldstein. And joining us today also is Dr. Ankush Gosain, who is also an associate professor of surgery and pediatrics, pediatric surgeon, and director of surgical research at the University of Tennessee Health Science Center and the Children's Foundation Research Institute. Did I get that all correct, Dr. Gosain?
Yeah.
Excellent. So without further ado, we're going to go to the first thing on our agenda. And I believe that, Allan, you have even a slide for us to lead us with some visuals.
I do, and it's my job to figure out how to share it. So let's see if this works. So far, so good?
First try.
All right, great. Well, thanks. It's really, thanks to you guys for hosting it and for everybody for attending. Ash and I thought that we would start with just sort of a little bit of an overview about Hirschsprung disease, and then tackle some questions that had come up ahead of the meeting, ahead of the symposium via email, and then do a Q&A. So Ash, do you want to take it from here?
Sure. I'll, if you could go to the next slide, Allan. Since it's on your screen, you're going to have to be my advancing assistant. So I guess I'll start this off maybe a little bit lighthearted. I think many families are familiar with this book, Everyone Poops. You know, I remember this book from when I was a kid and when my kids themselves were quite young. And it's, I would say that, you know, it's not exactly true and that my parents lied to me, and at least once that I know of, because not everyone poops. So if you go to the next slide, Allan. And really, the complexity is that pooping is not as simple as everybody thinks. So moving food and waste along through the GI tract from the mouth all the way down to your bottom requires a lot of work. And what that work is work that the enteric nervous system does to control motility. So how the intestine squeezes and relaxes to move things along as they get digested. And so the enteric nervous system and there's some pictures here, is really like the brain of your gut. So just like you have a brain up in your skull, there's this brain that's inside all of your intestine that is controlling how it functions. So how things are digested, how nutrients are absorbed, how contraction happens to squeeze things and move things forward, how the intestine relaxes to allow things to move into it. And this brain of the gut has over 500 million nerve cells, and there are many different types of nerve cells. And really, the complexity is probably the same, on the same level as the complexity of your brain. Next slide. And so I think, over the course of the next few minutes, Allan and I are going to touch on a bunch of concepts that go from, kind of the basic science and physiology of the gut through to, why do patients have the kind of symptoms that they sometimes have with Hirschsprung disease. And a lot of it depends on some definitions. So, we use some words kind of interchangeably. So we'll say neuron or nerve cell or ganglion cell, all kind of the same thing. And these are part of the enteric nervous system. And when we say enteric neuron, we're talking about specifically neurons that are in the gut. So part of the intestine, as opposed to neurons in the brain. And aganglionosis is a fancy word for Hirschsprung disease. It means the absence of ganglion cells, or the absence of these enteric neurons in the gut. Okay. That's a great brain of the gut picture. And so what is Hirschsprung disease? So Hirschsprung disease is a disease that children are born with where the enteric nervous system fails to form properly. And so they always have an absence of ganglion cells in the distal intestine. So close to the bottom in the anal canal and rectum, there's a missing enteric nervous system. And this happens about 1 in every 5,000 births. So in the United States, what that means is about 800 new babies are born with Hirschsprung disease every year.
So when you look at these pictures that are here, each little cluster is a group of nerve cells, and that's how they're organized in the gut. Obviously, much more dense than in this schematic. And these clusters of nerve cells are connected to each other by nerve fibers. That these yellow lines, they sort of signal from one nerve to another, or from the nerves to the muscles, to tell the intestine what to do. And this is what it should normally look like. But in Hirschsprung disease, specifically, and we'll talk about this, short segment Hirschsprung disease, you'll see that the lower part of the colon, this is the anus here, and so this is the rectum, doesn't have any of those clusters of nerve cells. And you'll sometimes hear the term hypertrophic nerve fibers. The nerve fibers that are normally thin yellow lines become really thick in that aganglionic segment. So Hirschsprung disease always affects the lower part of the intestine. You have to imagine that the whole problem is that cells, nerve cells that need to migrate from the esophagus all the way down to the end of the colon sometimes don't reach there. Sometimes they miss it by a few inches, sometimes by a longer segment. 80% of the time, children just don't have nerve cells or ganglion cells in that rectum and the sigmoid colon, and we call that short segment Hirschsprung disease. And the rest of the kids have either long segment, which is, it extends more into the colon itself, or even the entire colon has no nerve cells. That happens in about 1 in 20 kids. And about 1 in 100 times, the entire intestine may be lacking nerve cells, and we call that total intestinal aganglionosis. When a baby has Hirschsprung disease, most often we figure that out very early. A baby should pass their first meconium stool within 48 hours of life. And the babies that don't do that are at a high risk. We think they're likely to have Hirschsprung disease. They may have something else, but that's at least a suspicion that they have Hirschsprungs. What's interesting is that 50% of babies with Hirschsprungs do pass meconium stool within the first 2 days of life. So passing meconium as a newborn doesn't mean you don't have Hirschsprungs. The only thing we pay attention to is the kids that don't pass stool. The rest, we don't really suspect it until later because they get distended or they have really bad constipation, and that helps us to think about Hirschsprung disease in those other kids. And of course, some kids don't present with Hirschsprung disease as a newborn or even as an infant. Sometimes they show up later, a few years of age or even older, because they've had just such terrible constipation that doesn't respond to laxatives. And then those kids often will get a biopsy, and that's how we figure out that they have Hirschsprung disease. So how do we treat Hirschsprung disease in 2020? Well, unfortunately, in some ways, we treat it the same way we've been treating it for the past 72 years when Dr. Swenson described the first operation. The principles of the surgical treatment of Hirschsprungs are relatively simple. If this is the lower end of the colon and these dots are nerves, then this part that doesn't have nerve cells needs to be cut out, and this part up here needs to be brought down and sewn to the anus. And every now and then, for a variety of reasons, we can't do that operation right off the bat, so those kids get an ostomy. Some of you have heard the term Suave pull-through, or Swenson pull-through is another one, the Duhamel procedure. These are all different ways of essentially accomplishing the same thing. And in fact, no matter what operation is done, Swenson, Suave, or Duhamel, the outcomes in large studies are the same. The rates of constipation, incontinence, enterocolitis, it doesn't matter. One operation is not better than another operation. It all just depends on what the surgeon is used to, has experience with, and feels comfortable doing. Ash?
Yep. So I think that's fantastic. So I think probably the biggest shift in how surgeons and gastroenterologists and pediatricians think about Hirschsprung disease has happened over the last 10 to 15 years. So as Allan said, the surgery's been the same for 70 plus years. But I think the big shift is that we really started thinking about what happens to the babies that or young children that we do Hirschsprung disease operations for in the long term. So I think for a long time it was you do an operation, they're going to get better. And I think, probably everyone that's on this webinar knows that that's not the case, that there's a significant number of kids that don't thrive, that have less than quote unquote perfect outcomes. And so certainly in the US and in other parts of the world, we started trying to understand this by looking at long-term outcomes. Some of the places that are doing this the best are European countries where they have nationalized healthcare. People don't emigrate out of the countries very often. And so this study, which came out of Finland, looked at bowel function, quality of life, and showed that in adults that had had operations for Hirschsprung disease as infants, essentially all of them had, or the vast majority of them had poorer bowel function scores, quality of life, than adults without Hirschsprung disease. And so I think as we move forward, we're paying much closer attention to this and looking at this from the surgeon's perspective, but also from the patient and family perspective. And so I think there's going to be a lot more that comes out about this that then helps us refine how we take care of families over time. And so the kinds of problems that kids can have are varied, right? So they can be obstructive symptoms, which are similar to what the symptoms were before surgery, with severe constipation, distension and vomiting, and the need for dilations of the rectum or rectal irrigations. There can be fecal incontinence. We'll talk some about Hirschsprung-associated enterocolitis. Children may need additional operations. And all of this just makes sense that it would impact on quality of life for the kids and for the families. Next. And so we're going to talk a little bit about kind of common complications. The one that is, I think, the most severe or life-threatening is Hirschsprung-associated enterocolitis, and that's a picture of Harold Hirschsprung. And it's actually the complication that he described 130 years ago when he first described this disease. And so it's this infection with abdominal distension, fevers, foul-smelling stools. Depending on which study you look at, impacts about 1 out of 5 to 3 out of 5 kids with Hirschsprung disease. It accounts for the majority of deaths from Hirschsprung disease, and it happens both before and after surgery. So it's not that it goes away after surgery. And currently we treat it with a combination of antibiotics, either by mouth or IV, depending on how severe it is, rectal irrigations, and bowel rest, meaning oftentimes nothing to eat or drink, or just liquids to drink, things like that. Next slide. And so a huge challenge to understanding Hirschsprung disease or Hirschsprung-associated enterocolitis, I said there's that broad range of how often does it happen, And one of the problems is that we don't, not every center in the world defines it the same way. So, the way, what I call Hirschsprung-associated enterocolitis in Memphis, historically may have been different from what Allan calls Hirschsprung-associated enterocolitis in Boston. And so multiple groups, including ones that Allan and I are both parts of, are working to standardize how we define Hirschsprung-associated enterocolitis and how we treat it. And so this is just from one of the guidelines that we published in the last few years to try and break things into this is possibly enterocolitis, this is definitely enterocolitis, and this is severe enterocolitis. And then that paper that we published then has some guidelines for how should you treat it based on each of those three categories. Next slide, Allan.
So we were going to go through each of these issues that some kids have. Obstructive symptoms, you heard a little about enterocolitis, and then we'll also talk about kids who have soiling. Just to give you a broad overview of how pediatric surgeons think about these issues, work them up, and treat them. Ash, I think you were going to talk about the obstructive problems.
Yeah, so as I mentioned before, the obstructive symptoms really show up. The kids look like maybe they did before surgery, meaning they have distension, they have bloating, borborygmi, which is my favorite medical words. That's the rumbling, gurgling noises that your belly sometimes makes, vomiting, and then ongoing severe constipation that's really not responding to laxatives or anything else. And so, like I said, it's almost as if you hadn't done the operation. Go to the next slide. And so we think about this in a pretty systematic way to try and get to what's the cause. And so the first step for a child that's had, that's already had the pull through is to do a rectal exam and a contrast enema. And really this is because you're looking for, first and foremost, is there a mechanical problem? So just like when you have pipes in your house that may be blocked or something like that, that's the first step. Is there something that was mechanically not perfect about the original operation? Maybe the anastomosis, where that valve is connected down to the anal canal, is strictured, meaning it's too tight. Maybe it's kind of twisted, and so things aren't flowing through as well, or some other obstruction. And that combination of the rectal exam and a contrast enema are going to figure that out. And if it's one of those problems, the answer is dilation, if it's a stricture, or maybe a second surgery to revise that anastomosis and get rid of the twist or whatever that obstruction may be. Okay. If there's not a mechanical obstruction, then the next step is a rectal biopsy. And you may ask, why are we doing a rectal biopsy? One of the issues, Allan showed that slide with the ganglion cells in one segment and no ganglion cells in the next segment. It's not just an abrupt change where you go from ganglion cells to no ganglion cells. There's this area in between that we call the transition zone, where you go from no ganglion cells to some, to some more, and then you get to a normal number. And one of the things we're looking for when we do this rectal biopsy is, one, are ganglion cells there? And two, is it a normal number of ganglion cells, right? So you haven't pulled through that transition zone, which may not work like you need it to. And so if there's aganglionosis, meaning there's not ganglion cells there, or you're still in that transition zone, then the answer is a redo pull through, where you go and get rid of the aganglionic and transition zone segment and connect the fully ganglionated bowel down to the bottom. Sometimes we find that now we've crossed out both of those things and there's no neuromuscular pathology, meaning you've got good ganglion cells all the way around. So the next potential cause of obstructive symptoms is what we call internal sphincter achalasia, meaning you've got your sphincter, which controls, which has to relax for poop to come out. And sometimes that sphincter just doesn't relax. So when your rectum fills up with poop, it's supposed to sense that and relax so that you can have a bowel movement. And in some kids, that doesn't happen. And so what we try is Botox, just like Allan, I think, gets for his wrinkles, to relax the muscles. We inject it into the sphincters to relax the sphincter.
And no going off script, okay?
Yeah, sorry. and if kids get better, that's clinical improvement, then that's fantastic. And we repeat that as needed. Some kids never need it again. Some kids need it every few months. And every child is a little bit different, but that often solves that problem. And then if that doesn't solve the problem, we're all the way down to this right side where none of these other things are the answer. and we start looking for, is there a motility problem? So what is going on with the colon upstream that's keeping it from being able to empty? And there are lots of possibilities here. One is that the colon is totally dysmodal in a specific spot, and we need to just resect that segment and pull through a different part. Another is that there's generalized dysmotility, and we'll talk a little bit later about why that may be. But generally, these children are best treated with a bowel management regimen. So whether that's enemas or laxatives, and the enemas can be retrograde or antegrade. Sometimes the treatment is an ostomy. There are a lot of different possibilities here, and it's summarized just in that one box, but there's a lot of individualized decision-making that goes into it, that are discussions with the surgeon and the kid and the family.
One of the other common problems is fecal soiling, and a lot of kids experience this after the operation, and it can go on for some years. And it really has three basic causes. One is abnormal sensation. You need to know that there's something present in the rectum. If you're unable to sense that, then the stool will just come right through. The other problem is you really need to be able to have adequate sphincter, anal sphincter tone. It needs to be able to control the flow of stool. That's an essential component of being continent. So abnormal sphincter control is another problem. And then there's this other category that leads to fecal soiling, but we call it pseudo incontinence because it's not true incontinence. Kids who are severely constipated can just have so much stool in the rectum that they have overflow incontinence. Liquid comes out around the fecal impaction and just drips out of the bottom. And that's one type of pseudo incontinence. The other one is due to a phenomenon called hypermotility of the colon. Normally the colon squeezes at a certain rate and frequency, and also at certain sort of strength. And after surgery for any colon surgery, but also pull-through surgery, the colon can squeeze more quickly and more frequently, and that can lead to just uncontrolled bowel movements or soiling. I won't go through this, but just suffice it to say that I think any pediatric surgeon or gastroenterologist, whoever's taking care of a kid with Hirschsprung's, needs to have an algorithm. And a group of us in pediatric surgery are interested in Hirschsprung's have written a few papers on this kind of thing to just sort of lay out a plan for when a kid after a pull-through has, as Ash discussed, obstructive symptoms, or in this case, incontinence or soiling. They have to have a clear plan on what are the potential problems and how to address them. And for us here, for example, it's essential to know, do you have true incontinence? Can you just not control your bowel movements? Or do you have pseudo incontinence? Because the treatment for overflow incontinence is laxatives. You don't want to give laxatives to someone that has true incontinence and can't control their bowel movements. And at the end of all of this, whether you're giving a high fiber diet and laxatives and stool softeners because you're on this side, the obstruction side of the algorithm, or you're giving things to slow down the bowels because you have too much motility in the colon. If after all of that, nothing works, you're left with the bowel management that Ash was discussing. And again, bowel management takes a variety of forms, but it's either laxatives or enemas. And the enemas can be rectal enemas or enemas through an appendicostomy or a cecostomy, which we call antegrade enemas. And finally, an ileostomy or a colostomy may be what the child needs. We've made tremendous progress in Hirschsprung disease. We do the same basic operations since the beginning, but they've been modified a lot, and they're much more effective operations than they used to be. Pediatricians, neonatologists, everyone's more aware of the disease, so we diagnose it earlier, which is a good thing for Hirschsprung's. The mortality is very low in North America. I mean, to the point that we don't really discuss mortality, fortunately, with patient, parents. We have a much better understanding of the genetics. You'll hear a little bit about that from Ash. We know what causes Hirschsprung's disease during development. As I said, the operations have gotten better, and there is, as Ash mentioned, much more awareness. that as surgeons, we can't just follow these kids for a few months and then say goodbye. I mean, it's a lifelong condition. Issues do come up later, and we need to follow these kids closer. And we're learning so much more about how Hirschsprung's affects GI function and quality of life into adolescence and adulthood. And I'll mention at the end some newer treatments that are on the horizon. Ash, you want to unmute?
That would probably make it easier for people to hear me. So I think one of the most common questions that I get after we've diagnosed a baby with Hirschsprung disease and gotten through the initial stuff, often families are thinking about having another child, and they ask, what are the chances of the next baby having Hirschsprung disease? And the answer is not a very simple answer as far as it's X% or Y% or whatever. And so my approach, and I think this is probably true many places, is I offer to every family with Hirschsprung disease to meet with one of our genetic counselors, and they talk about all the different things that confer higher risk or lower risk. Maybe there's genetic testing offered, maybe there isn't. But this is from a recent paper that kind of goes through what are some of the things that impact that risk from low risk to higher risk for the next kid. And so on the far end of high risk are mutations that we find by genetic testing in diseases that we know confer risk. And mutations in any of these things is greater than 1,000-fold increased risk. So it's not 100% chance, but increases the risk. On the other far end of the spectrum is there's no family history of Hirschsprung disease. You meet with the genetic counselor and no identified genetic risk is identified. The baby that has Hirschsprung disease is a girl as opposed to a boy. That's very, very low risk of the next baby having Hirschsprung disease. And then there's a lot of stuff in between. And so I'm not going to go through all of this, but it's just to show that there's a lot of complex or complexity into how Hirschsprung disease is inherited. And so I encourage families that are thinking about this to talk with their surgeon or pediatrician or gastroenterologist and see if there's genetic counseling that's available. Next slide, Alan. So I think the next big deal, and we've kind of touched on it some, is that we showed you this picture where the healthy segment is connected down to the anus. The disease segment that's aganglionic is taken out, and the healthy segment is connected down to the anus, or maybe an ostomy is made. But it's not that black and white. So what has traditionally been considered healthy or quote unquote normal, I think we now recognize is not normal. And a lot of this work has been done by multiple laboratories, including Allan's, including mine, including others, to show that the quote unquote healthy segment may actually not be totally normal. So it may have fewer neurons, the ganglia may be smaller, there may be an imbalance of the kinds of neurons that govern contraction versus relaxation. And all these things may explain why even after your surgeon comes out and talks to you and says that surgery went perfectly, that your child doesn't do perfectly, meaning it has problems like constipation or soiling or things like that. And so this is, I think, going to be a huge area that we figure out over the course of the next decade. But I think conceptually, this is now reasonably well established that the normal bowel is not totally normal.
Well, I just thought we'd finish on this, the sort of the hope that there may be newer treatments in the future. And one area that several groups around the world are working on, including my lab, is this idea that, Hirschsprung disease is the absence of nerve cells. And in this picture, it would be in this aganglionic segment down here. So can we get neurons, neuronal stem cells, take them out of a normal, seemingly a part of the colon that has nerve cells, grow them in a dish, and then implant those neuronal stem cells into that aganglionic segment of the same kid. It's his own cells, so you don't need immunosuppression. And there are many advantages to this. Here, you're actually treating the disease. You're restoring neurons to the area that's missing them. You may be able to avoid surgery in many cases if this were to work. You don't have to remove the rectum, which is a super important part of the intestinal tract. And as a result, you would not injure things the way that surgery has, the risk of doing. The idea would be that when we diagnose Hirschsprung disease, the first thing we would do would be to get neuronal stem cells from the intestine. We'd grow them up in a dish, and once they're grown up, which takes a few weeks, we would then transplant those cells into the part of the colon that has no nerve cells. So this has come a long way in the past. It probably started about 10 years ago. These types of experiments are done in mice, some mice with Hirschsprung disease or other types of diseases. And we find that those mice actually have improved intestinal function after stem cell treatment. It's a long way from where things are now to actually doing human clinical trials in children. But that is definitely on the horizon. And I would hope that within the next several years, we can actually try to start clinical trials for this kind of therapy. And I think it offers hope that maybe 72 years of the same operations is great. And it's still going to be the right thing for a lot of people. But maybe there's a newer way. And just to give you to know that a lot of people are working on making things better for kids with Hirschsprung disease. So that's all we had, Tory and Liz, and we're happy to take any questions.
Okay, great. Well, thank you so much for that. I know that a lot of people were working throughout today, so they have sent in some questions via social media. Also, if anybody has any questions, there is a little tab that has a raise your hand, and we can take questions that way as well. So we can line that up in the queue. But in the meantime, I have one here via Facebook from Laurel, who is wondering if there have been any studies that compare outcomes with children who have had what she considers to be unsuccessful pull-through surgeries, meaning that her child is dependent on rectal irrigations or colostomy bags or cecostomies. And she's wondering if the outcome of that, if she should expect that her child as an adult would have the same success as a child who maybe, had the pull through and things went better. So she's looking for an answer about the outcome later on, and if there's been any studies. So
I guess I can I'm interested in Ash's thoughts, but I think, first of all, it entirely depends on what the reason is that things aren't going well. And so those algorithms that we presented, presumably it's around either the issues that the child can't stool easily and so has those obstructive symptoms, or maybe it's because of severe fecal soiling and accidents. Whatever it is, figuring out where the problem lies as best as we can should guide the treatment and would give us a better idea of what the long-term outlook holds. It turns out that a lot of kids who initially don't do well improve in their GI function over time. Whether it gets to, it may not get to exactly normal as compared to somebody who doesn't have Hirschsprung, as Ash showed in the studies that have been done. But there is optimism that with time, things can get better. I would say that with the proper therapy, an awareness of what medications, diet, are there allergies playing into it? Are there other factors that need to be considered, can make a huge impact on how what the clinical outcome will be. Ash, did you have anything to add?
Yeah, so I completely agree with Allan. A lot of it depends on what the underlying cause or reason for needing irrigations, et cetera, is. But I think kind of two things that I've seen in my own practice. So one is that as Allan said, some kids outgrow this or it gets better with time. And I think some of that is just, it can be really challenging to, have a 3-year-old who is pretty strong on an enema regimen. And there can be some, fighting back and forth that goes with that. And as kids get older and they're able to kind of engage a little bit more in their own care, understand reasons for things, that part becomes easier. And certainly into teenage years, often kids are trying to, create their own independence and become really engaged in having their bowel movements become, a priority. And so I think that's one potential. And then the other is that I put up that graph of, bowel function, quality of life. And that's, kind of comparing Hirschsprung's patients to people that didn't have Hirschsprung disease out in the population. What that graph doesn't show you is that if you look at long-term bowel quality of life from some of these same groups within Hirschsprung's patients, they don't assess themselves as having bad quality of life. So they're happy. And it's only when you say, okay, when we really look at how many bowel movements a day do you have compared to somebody that never had Hirschsprung disease, that you start to find some of these differences in the long term. And so it's not that your child is going to grow up happy for this life. The vast majority end up very happy and have good quality of life. It's who you compare them to that, sometimes creates that distinction.
That is a great point that is worth mentioning again. Repeatedly, studies show that when you ask quality of life in these patients, the parents say, oh, they have a poor quality of life. The kids are perfectly fine. And that has to do, when you're born with a condition, it's just who you are and what you know. And they can have a very fulfilling, full quality of life, even with some of the, setbacks that they encounter.
Yeah. And, on that piece on adolescence, there's one kid in particular that stands out in my mind where we struggled for years, double-digit age, getting into adolescence, and still in pull-ups because he was continuing to have accidents, and it was tough to get a good regimen that worked for him. And one day he came to the office and he said, hey, I've got a girlfriend and I need to get out of pull-ups. And over the course of the next 6 months, it worked, right? He was totally engaged, had a motivator that, wouldn't have been the first one that I thought of for him, certainly at a younger age. But he totally engaged, and within 6 months was out of pull-ups and remained clean, and still is to this day. So sometimes the kid really has to find their motivation as well. So,
excellent, thank you. Okay, we have a question here from Tara. She has a 5-year-old who has total colonic Hirschsprungs and has had 2 pull-throughs. We've been unable to slow her down, and we are also unable to potty train. Any help? Any advice? Question mark.
Yeah, so I'll start if that's okay, Allan. So I think babies that have total colonic Hirschsprung disease are a challenge because you don't have the colon, and part of the colon's job is to absorb liquid and turn liquid stool into solid stool. And so every child with total colonic Hirschsprung disease needs some work to get to controllable bowel movements. And what that work entails varies from child to child. When you say, when this mom says that they haven't been able to slow her down, I think, again, there are multiple possibilities there, right? So, it could be as simple as diet and things that need to be changed to, decrease, things that'll increase liquid stool output, increasing fiber, things like that. But it could also be downstream, and you need to ensure, I think, like the algorithm that Allan went through, that there's the ability for continence and that the sphincters work and things like that. And so, taking a really systematic approach to what is causing the inability to slow the child down will help answer that question.
Okay, great, thank you.
I don't know, Allan, other thoughts?
No, I agree. I agree with your comments. It's a challenging problem, and it really has to be tailored to the individual child. So it's hard to make generalized comments about that. But I agree with what you said.
Yeah.
Okay, I have quite a few questions here because, again, a lot of people are excited to see the post when we put it on Facebook later. So Charlotte is wondering, do we need to be especially careful with our Hirschsprung's kids and COVID? And is there any new information on that front?
I mean, it's a good question that a lot of people are asking. We know from Dr. Fauci and a lot of research that has been done out of this CDC that the risk factors for COVID and who needs to be concerned. And, it's the ones it's age over 65. Obesity is probably the greatest risk factor for COVID. Hypertension, diabetes, there's COPD, smoking. But GI issues is nowhere on that list. So kids with GI problems, Hirschsprung's disease, are not at greater risk of getting COVID or of having a complication from COVID than any other child. the one thing to consider is that in children, one of the common manifestations of COVID is GI symptoms. So abdominal pain, diarrhea, vomiting. And so if you have Hirschsprung's and happen to get COVID, you may want to consider the possibility that the exacerbation of underlying GI issues could possibly be related to getting COVID. That's the only thing I can think of that sort of links the two conditions, but I don't think parents with Hirschsprung kids need to be more worried than other parents. Ash, anything?
Yeah, no, I completely agree with you, Alan. And I think you and I talked about this sometime in the last few weeks, because we haven't seen any uptick in COVID and Hirschsprung's patients. And so I agree with you. I don't know that there's any increased risk. I think the potential masquerader is Hirschsprung-associated enterocolitis. And so children that have COVID, that have GI symptoms, bloating, diarrhea, et cetera, that may look just like Hirschsprung-associated enterocolitis. And so kind of figuring that out would be, one thing to keep in mind. But again, I've not seen a huge uptick in children with HAC coming into the hospital over the last 6 months.
Great, thank you. Okay, and first of all, I also wanted to say Megan jumped in not with a question, but said that she has 2 children who have Hirschsprung's disease, and she just wanted to say thank you and noted that information has been extremely helpful. So that popped up. Also from Amber. Amber is wondering how often she has a sister who is 23 years old. They are suspecting that she potentially has Hirschsprung's. How common is this that she would be diagnosed this late in life?
It can happen. We've all seen it occasionally. It is really, really uncommon. And the majority of the time, I assume it's because of constipation. Constipation is exceedingly common in young women. Young and older women. The only way to know, I don't know why they're suspecting Hirschsprung, which is really quite unlikely, but it's possible. And if the concern is there, the only way to know is with a rectal biopsy.
Okay, great. And then I have another question here from Kyle, wondering how important it is to start looking at dietary changes. He's an adult male, Hirschsprung's diagnosed as a child, always had chronic issues, wondering now that he's in his 30s, is that something he's never consulted with a dietitian, but at this point in his life, is that something that is now considered a part of Hirschsprung's treatment?
Yeah, so I think there's never harm in consulting with a dietitian. And very often for our children with Hirschsprung disease, have them meet with the nutritionist or dietitian at different stages, right? Because how your GI tract responds to different foods varies from when you're 6 months old to 3 years old to 15 to 30 years old. And I think, as I mentioned before, there's a huge subset of children that go on to be adults with Hirschsprung disease where their symptoms can be managed with diet. And so knowing the kinds of foods that trigger constipation versus diarrhea, a little bit is individualized, but some of those can be put into broad buckets, and that can help. It's not always just diet that's going to work, but I think that diet is a good place to start. And it's hard to overcome bad diet that's going to trigger symptoms with medication.
And I also, Liz, we've the surgeon community doesn't often talk about the association of Hirschsprung with food allergy. I've noticed it a lot in my patients. You've seen it in the REACH surveys we've done, and it's been written about like once or twice. But I think when you're, if you're older and I've been surprised, for example, we'll have kids who have high output stool, and we just take them off dairy, and it's like everything changed. Mm-hmm. So back to that, the mom whose kid has a lot of diarrhea with the total colonic aganglionosis. So it may be that a food intolerance, and it doesn't have to be an allergy, but an intolerance to milk or fruit or something, that person should definitely see a dietitian because those factors are really important and it's worth exploring them.
Okay. Great. That is true. We certainly hear that a lot through the REACH community. Feedback from families and parents that allergies or food intolerances play a huge part in the overwhelming, every day of their child. So I definitely agree there from a non-scientific perspective, just the mom squad. Okay, Carol from the UK wrote in. It's like 10 o'clock at night there or something, but she would like to know, she has a daughter who has one child who was diagnosed with Hirschsprung's. What is the likeliness if her daughter and husband were to have another child that would be diagnosed with Hirschsprung's? Apparently her granddaughter is short segment. So.
I believe, Ash, you're gonna correct me if I'm wrong. If the child is a girl with short segment Hirschsprung disease, the chance of the next child having Hirschsprung, and it'll vary if they're a boy or a girl, but it's very low. You're talking at most 3 to 5% risk.
Yeah, and so Alan's spot on. The risk is higher, probably about 4. So I think that 3 to 5% is even high. So in the absence of any genetic predisposition, if the child with Hirschsprung disease is a girl, there's no family history, it's short segment disease, very low risk. The risk goes up by about 4-fold if the baby with Hirschsprung disease is a boy. But still, it's quite low, right? So on that slide that I showed, that's on one end of the spectrum, the good end of the spectrum, as compared to known genetic mutations where the family has a RET mutation, as an example. That's over 1,000-fold risk. And then there's a lot of in between. And so I think if they're thinking about having another child, one of the easiest things to do to try and put some more concrete stuff around it is to meet with a genetic counselor.
I would say I agree with, the genetic counselor thing is a complicated topic though, Ash, because some know nothing, most know nothing about Hirschsprung. So they kind of read about it and try to figure it out. Then the question is, what will you do with the information? So if to be useful, they'd have to draw blood. They'd have to figure out what the genetic mutation is in the first child. And the truth is that even if the next child has the same exact mutation, they may not have Hirschsprung disease. The genetic inheritance is so complicated. So I think being educated by a geneticist who knows something about Hirschsprung disease is definitely a good idea. But we have to think about, I'm not sure what you do with the information because it's so unpredictable, really.
Yeah, so I mean, exactly to your point, I have a family that I took care of, not super recently, but maybe within the last decade, where their daughter had total intestinal aganglionosis, and received genetic testing, et cetera, and actually had a known mutation, and then they had another child, and everybody was concerned about, will this baby have Hirschsprung disease? And that baby stone cold normal. And so it didn't stop them from having the baby, and the baby was totally normal. And so it's all about, exactly what you said, how are you going to use that information?
Okay, great. Okay, and I know that we have a question from Benjamin, or a statement, or Benjamin is joining us. I think, Nicole, you have to just put your hand up. He texted and he'd like his Dr. Goldstein time. Is he there?
Oh, yeah.
All right, where are you, Benjamin? Hi, Benjamin. You got everybody here? Dr. Goldstein's there.
Hi, Benjamin.
Hi. Hi.
Hi. How's the weather in Denver?
Good.
And tell them how well you're doing.
I'm doing really good.
Great. It's nice to hear your voice, Benjamin.
Yes, and his cecostomy healed lovely.
Great. Great. Life without a cecostomy is good. And life, if you need a cecostomy, is good too.
Yep.
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 Bye.
Bye, Benjamin.
Bye, Benjamin.
Nice to meet you, Benjamin.
Maybe you could just give us a brief little history on Benjamin, Dr. Goldstein. I know Nicole would be totally fine with that, but just so everybody else knows.
I mean, Benjamin's a good example of somebody who had a pull through and then had some residual, maybe transition zone, or just there was a segment there that wasn't working well. He went through all sorts of workup and treatment, ended up with a cecostomy for antegrade enemas. And what he really needed was a redo pull through, and then he could have his cecostomy removed. And he's done great.
Yes. And he's just a doll. Okay, so are there any other questions? We can give you a minute. I think that we've got them all. So with that, I guess we are closing the question and answer period with Dr. Goldstein and Dr. Gosain. So thank you so much for doing that today. Information was amazing.
Thank you.
As always.
Yeah, thank you.
And so Tory, I think now we're flipping over to the parent panel, and I'm not sure if anybody, parents that are out there, want to join in or have much that they want to say, but I would love to throw it over to you, Tory, and maybe you can share with us a little bit about what it's like to be a parent of a child who's got Hirschsprung disease and some of the things that we don't always talk about. We don't always talk about the emotional impact of it. And I've often said, as a parent, that's like a whole other ball of wax. So there's the medical side of it, but there's also, the constant fear. I'm convinced I have a little bit of PTSD from all of it.
Absolutely.
And so
I think what we notice, I mean, myself as a parent, and I think back and like Dr. Goldstein said earlier, is that this is what they were born with. This is what they know. This is what they've grown up with. So in my opinion, in my experience, it's always worse for the parents. And so we're always worrying, he's got a stomach ache, his stomach's distended. Does he have enterocolitis? Right. How many more times does he have to vomit before I bring him to the hospital? Well, let me text Dr. Goldstein. It's a constant worry. And I've worked really hard, myself and Avery's other mother, to make sure that we treat him like a quote unquote normal child. We've had nurses tell us, don't bring him to water parks. So it's like, well, all the other kids get to go to water parks. How do I tell him he can't go? So, we've really done our best to let Avery kind of guide the way for us. And I will tell you that every day of the week, he is a stronger individual than I am. I worry a lot. And some of that has come on to him. I've gotten a few more situations as he's getting a little bit older that worry me. So when he he poops 7 times a day. He has total colonic Hirschsprungs. And I remember talking to Dr. Goldstein and he said, well, he should really only be pooping 3 to 4 times a day at this point. And I'm like, what? I mean, I thought this was good. He was down from 10, which I think is great. And that worried me. But you know what? He's been pooping 7 times a day for forever. But what he started with is, when he has to poop, his belly gets really distended, and he started thinking that he was fat. So he would be eating and he'd have to poop, and I'd watch him lift up his shirt and look at his stomach, and then he'd say, I'm not hungry anymore, and he pushed his plate away from him. And I was worried about an eating disorder, and I then had to explain to him, bud, you can't afford not to do this. Your belly's getting big because you have to poop. Well, then we noticed that he kept looking at his belly and trying to poop, which is also another form of an eating disorder. So, we really had to struggle with this in the last year. And every day I hear, Mom, am I a healthy kid? Should I have this snack? Am I okay? And, we're struggling with some different things now as he gets a little bit older and starts to understand a little bit more.
Right. And
at the same time, not understand.
Right. Of course. And how old is he?
He'll be 10 in December.
He'll be 10. So he's at that point too. My son, Malachi, he, from Nicole, we have one here too. Question, or Nicole's going to jump in a minute, but he is going to be 12 in November. And it's the same thing, really conscious of, wow, suddenly what he looks like. And am I fat? Because he gets his distension, and our kid's going to, make fun of me. And he's always wearing oversized hoodies. And we're going through all those social things, which as a parent kills you.
It's nice to know like that it's normal, and there are other people out there that are going, through the same thing, because with a community like this, we can all be there for one another. And I was always of the mind, I remember when Avery was first born and he had all these problems, Bridget's on all the forums, and people really tend to only post on these forums when bad things happen, and because they're looking for guidance, but we never hear the success stories. And reaching out to those people who were worried about kids with total colonic potty training, I have to tell you that we had absolutely no problems. We tried to get Avery to potty train at 3, and he just wasn't ready, and we decided just wait till he's ready. And 2 months later, he was ready, and he has been potty trained since he was 3, and he has never once had an accident, total colonic Hirschsprungs. So it's doable. It's, I think a lot of the times, and I know from my family, because I am always worried and always, I feel like I put my worry on him. And I think that if we just kind of let them do their thing sometimes, I I think it helps. I think them getting anxious, we know that anxiety affects our gut. Those of us who don't have Hirschsprung disease, I mean, how many of you get nervous and you have to poop, or your stomach starts making, noises, or it's uncomfortable? So if we start putting our anxiety on them, I find it problematic. So I do my best not to do that, but it's difficult in certain situations.
Right. Of course. Can we unmute Nicole? Because I know Nicole is jumping in. Nicole, are you there?
Hello. Hi, ladies.
Hi, Nicole. So I'll let you talk because I could read it out, but it would be, I think you should just join. So
Oh yeah, I just wanted to jump in what Tory was saying. We had something similar, not the exact same, but Benjamin was afraid to eat, period, because he knew that if he ate, it meant he had to poop. So for the longest time, my husband and I would be like, we will buy you McDonald's, like whatever you want, just put food in your mouth. And he was so afraid to eat for fear of having to go to the bathroom.
We're having those issues right now with COVID because he does not want to be in a public bathroom. So if we're out and about and, we offer to stop and get the kids ice cream, he knows ice cream is one of those triggers. And he's like, no, I don't want any.
Right.
And he won't be honest about it. We know why he doesn't want it, but he won't be honest about it until after the fact. Mom, the real reason I didn't want ice cream is because I didn't want to have to poop in a public bathroom.
Right.
Our kids sound very similar. Benjamin does the same thing. I don't want pancakes today. I'm good with no pancakes because he knows pancakes are gonna make him have to go.
Yeah.
Mm-hmm. Yeah.
Another thing that Avery's doing in school right now, so he has a 504 plan. He generally gets to use the nurse's bathroom, but because of COVID, they can't use the nurse's bathroom anymore. So they've actually given him his own bathroom. It's the teacher's old bathroom. Nobody else goes in it but Avery. But what he's upset about is that it's far away from his classroom. So it takes a long time and people are going to get suspicious.
Right.
He's still embarrassed by it. And I almost wish, I always thought because he was a boy, maybe that wouldn't happen because boys don't really care about that kind of stuff, but he does. He does.
Yes.
I
think they do.
Go, Liz. Sorry to interrupt.
No. I was just saying, I think that they do. I know Malachi is the same way. In his old school, he used to have a bathroom that was sort of designated because he had to get rid of gas a lot throughout the day. So he did not want to go into the bathroom where the other kids went. And now he's in a different school and he's, using the same bathroom. And he's very funny because he's can't wait for me to pick him up at lunch because that's his time because he wants to just go home and let that happen, right? But it definitely, that is one of the factors. Like public washrooms are definitely a conversation in our home too. Go ahead, Nicole.
Oh yeah, I was just gonna say, Benjamin was on a 504 too. We are fully remote learning this year. But one of Benjamin's things was at the beginning of each school year, he does a presentation of himself. And he said, he stands in front of his class every single year and says, I have a rare disease and I poop a lot. And sometimes I have bad gas. So you might hear me fart. And he is so, he just starts it off that way. He's like, Mom, let's just get it over with so that nobody even has to ask me, why are you taking so? So he just tells everybody flat out. And I'm pretty proud and impressed by him because he's only 7. So he's been doing that for 2 years. And I just figure, let everybody know. I mean,
yeah, that's awesome. I've tried to get Avery to do that. He won't.
Oh,
yeah, Malachi, forget it.
No way.
Yeah, no, but that is awesome that he
It is awesome. I wish Avery would do that. Yeah.
Yeah.
We actually bring Avery to the 504 meeting and we ask him to tell his teacher what it is. And he's like, no, Mom, you can do it.
Yeah, definitely. Kids are all different. Hey, it's hard to know as a parent. I've found it so interesting, especially running the social media for Reach and hearing, all the feedback and all the things that come in. And one of the commonalities I think is, we obviously have all the concerns medically and, there's a million questions about that, but there is this, and it is true. I don't know that the kids feel it as much, but there is this sort of angst that all parents seem to share. And it always is around sort of the social aspects of their kids. And because there is really nothing more painful than when your child is being picked on or bullied or somehow different or excluded or what have you. That is the worst. And we certainly hear that a lot from the community. And it would be interesting to explore that a little further about how we can, tools and tips maybe that we can create for helping your child to deal with those things. And maybe for the parents, maybe we need it more than they do. I think maybe actually.
I think we just have to let them be them. And that's the biggest thing. Avery, this is the first year he's gone without a shirt at the beach because he didn't want people to ask about his scars. We used to be like, Bud, why don't you just take off your shirt? And no. And so we finally left it alone and now he takes his shirt off. So I think we've learned to let him be him and only interject in situations that it's necessary.
Right. Excellent. Okay. Well, I don't know if there's any other questions or thoughts from the parents or families. Grace, you're over there moderating. Nothing's coming in. So I would love to just put this out there because I know this will be posted later on social media that this is obviously the first time we've done this. And I think that we are talking about potentially doing a series of them on different topics. I think it's been quite useful and informative. That's the feedback we're getting. And maybe also hear from other families and parents about things both medically and non-medically that you would like to see Reach be able to create for, in terms of how can we create communication that will be most helpful. Tory, what are your thoughts on that, having sort of a feedback forum?
I think that would be great. I think having, I think a lot of people are afraid to ask questions necessarily in situations like this, just because they're not sure if they're alone. But I find that all the questions are so similar and we all have really similar, and you can just see what just happened with just the board. We all, have talked about, we all have situations and experiences with the kids just being nervous to poop or nervous to share their stories. I think throw it out there because you're not the only one who has that question. Somebody else has that question. You're saying what somebody else is afraid, to hear. And I think having this awesome community, this awesome network really helps. I wish I had this when Avery was born and he was really sick, and I was afraid to go on these forums because the information was just so bad. These kids who were doing well and had to have other surgeries, and I'm like, oh, I can't even listen to this. But what's been so amazing is to find this group of parents, even from the very first symposium I went to when Avery was an infant. I just felt so much better knowing that what I was feeling, it was normal.
Yes.
You're afraid.
Yes. Absolutely.
So I think regular, things like this would be great where people just ask questions and we can all get on to help.
Okay.
I hope that answered the question.
Yeah, you did. Thank you, Tory. And so I know that Eric and Isabel are on here. So Eric, I don't know if you, if there's anything you'd like us to add before we close off here. There he is.
Hi there. No, this has been great. It's been wonderful to hear Ash and Allan, and of course the other members of the parental Reach board talk about their experiences in very personal and heartfelt ways. I hope that for the audience, we're talking about the right things. That to Liz's question, we want to talk about topics and create content that serves this community. So we need to hear from you on what's the most important thing to address. But Isabel and I, we're reflecting on how much progress actually has been made since our son Adrian, who's now 14 years old, was born. And it's great to see, for example, these flowcharts that help not just parents and families, but the doctors themselves navigate the decision-making. I don't think we were ever presented with anything so clear-cut or clinical and helpful. So that was a great thing to observe. And then of course, the idea of stem cell therapy being on the horizon for all of us to look forward to, even if it's way out there in the future. It's wonderful to think about that. So anyhow, we're just delighted that we could be a part of this virtual event. Thanks.
Thank you, Eric and Isabel. So then I guess with that, I will say thank you to everybody who's joined. Oh, and Dr. Gosain says thank you for the opportunity to participate. Again, welcome any and all feedback. This will be posted later on social media. And from everybody at Reach, thank you for your participation today. Have a great day.
See ya.
That was great.